Okay, and the ascorbic acid can reduce very ferry to ferro from non-Hem iron sources and thus enhances iron absorption. And the chemical and biological properties of ascorbic acid suggest that it can act as an antioxidant in vivo. Lipid peroxidation and oxidative modification of low-density lipoprotein are implicated in development of atherosclerosis because it protects against oxidation of isolated LDL through the scavenging reactive oxygen species. And the ascorbic acid acts as synergistic antioxidant together with alpha-tocopherol to prevent LDL oxidation. And this is the overview of the recycle of the hydroascorbate and ascorbate, alpha tocopherol and alpha tocopheroxy radical, and so on. Next, factors affecting the vitamin C requirement. First one, the smokers and passive smokers. The smokers have lower plasma and leukocyte vitamin C levels than non-smoker, due in part to increased oxidative stress. So that's why the smokers need 35 milligrams more vitamin C per day than non-smokers. Second one, infants with evaporated or boiled milk. Most infants in developed countries are fed breast milk and or infant formula, both of which supply adequate amounts of vitamin C. And for many regions, feeding infants evaporated or boiled cow's milk is not recommended because this practice causes vitamin C deficiency because cow's milk naturally has very little vitamin C and heat can destroy vitamin C. Third one, individuals with limited food variety, although fruits and vegetables are the best sources of vitamin C, and many other foods have small amounts of this nutrient. And through a varied diet, most people should be able to meet the vitamin C RDA, or at least obtain enough to prevent scurvy. Fourth one is people with malabsorption and certain chronic disease. Okay, some medical condition can reduce the absorption of vitamin C and or increase the amount needed by the body. People with severe intestinal malabsorption uh, and some cancers might be at increased risk of vitamin C inadequacy. And low vitamin C concentrations can also occur in patients with end-stage renal disease on chronic hemodialysis. Okay, next, the vitamin C metabolism. Ascorbic acid is the water-soluble and is well absorbed from the gastrointestinal tract. And the ascorbic acid is metabolized in the liver and to some extent in the kidney for excretion. And the mechanism is the simple passive diffusion can cause the for some of this movement. The major transport is carrier mediated for ascorbate. There are sodium cotransporter that actively transport ascorbate into cells. Meanwhile, dehydroascorbate is taken into cells by the facilitative glucose transporter. Cell accumulation of ascorbic acid occurs as dehydroascorbate is converted to ascorbic acid. This also serves to keep the intracellular concentration of dehydroascorbate low uh, for the favoring or supporting uptake into the cell along a concentration gradient. Neutrophils are one of the leukocytes utilize ascorbate as a reductant to generate peroxide for ocular activity. And inside the neutrophil, dehydroascorbate is converted to ascorbate by dehydroascorbic acid reductase that utilizes glutathione as a reductant. So, the increase in the intracellular ascorbic acid concentration are linear with the increase or compared to the increase of oxidative burst reactions. Diabetes can influence ascorbate cellular transport. High glucose can compete for ascorbic acid, presumably by interfering with ascorbic acid uptake via the glucose transporter isoforms GLUT1 and GLUT2. GLUT1 is the glucose transport 1, GLUT2 glucose transport 2, which transport the oxidized form of vitamin C is namely the hydroascorbic acid. The hydroascorbic acid also enters mitochondria via the facilitative glucose transporter 1 and accumulates in the mitochondria as ascorbic acid. Specific active transporters for ascorbic acid have also been identified and are found in tissue that accumulate ascorbic acid. Ascorbic acid is easily absorbed, similar to the cellular uptake of ascorbic acid by red cells and neutrophil. Enterocyte uptake is sodium dependent. And this is the diagram of the metabolism of vitamin C through the active transport and facilitated diffusion, active transport for the ascorbic acid and facilitated diffusion for the dehydroascorbic. Both ascorbate and dehydroascorbate can enter enterocytes via sodium-dependent vitamin C transporter and glucose transporter. The absorption pattern of ascorbate is opposite to that of glucose transport, as ascorbate is better absorbed in ileum of the small intestine and in smaller quantities in the duodenum. For its part, the hydroascorbate is better absorbed in jejunum, where very little absorbed in ileum. For the efflux mechanism, ascorbate release are mediated by an exocytosis process or by its species through gap junction has also been proposed as transporter. Such as the hydroascorbate, it is reduced to ascorbate inside the enterocyte by complex recycling mechanism, and then it exits the cell and goes to the intracellular space where it reaches the bloodstream through fenestrated capillaries that supply the mucus of the small intestine. What is the efflux pumps? Efflux pumps are protein of transport and its response for expulsion of potentially harmful substances including antibiotics. And then the fenestrated capillaries are capillaries that have tiny opening or pores. Fenestrated capillaries exhibit pores in the endothelial cells that allow small substances to pass through. Okay, this is the efflux mechanism. The exocytosis is the fusion of secretory vesicles with the plasma membrane. And the oral vitamin C produces tissue and plasma concentration that the body tightly controls and is excreted in the urine. How about if the person excess or lack of vitamin C? Hypervitaminosis C occurs when the person excess vitamin C doses. Large doses may cause gastrointestinal discomfort, headaches, trouble sleeping, and flushing of the skin. And oxalate is an end product of ascorbate catabolism and plays important role in kidney stone formation. And excessive daily amounts of vitamin C can produce hyperoxaluria. And for the vitamin C deficiency, acute vitamin C deficiency leads to scurvy. The timeline for the development of scurvy varies depending on a vitamin C body store, but signs can appear within 1 month of little or vitamin C intake below 10 milligrams per day. Initial symptoms can include fatigue, probably the result of impaired carnitine biosynthesis, malaise, and inflammation of the gums. And as vitamin C deficiency progresses, collagen synthesis becomes disrupt and connective tissues become weakened, causing fatigue, ecchymosis, purpura, joint pain, poor wound healing. So it can cause bleeding, hyperkeratosis, and corkscrew hairs. Additional signs of scurvy include depression as well as swollen, bleeding gums, and loosening or lost teeth due to tissue and capillary fragility. And also iron deficiency anemia can also, if the person lack of the vitamin C. Okay, this is the summary of this topic. Okay, thank you for your attention.